It's time to kick things off properly. We've got our first speaker. We've got Professor Christina Pagel, who's going to be joining us on stage in just a second, and she's going to be talking about the UK's response to the COVID-19 pandemic. She's the first speaker for a very long time. I'm not going to condescend to you to get you to practice clapping, because I know every one of you is ready to get this going. So please, welcome to the stage, your first speaker for QED 2022, Professor Christina Pagel!
Hi, everyone. This isn't going to be a fun talk, so if that's what you were expecting, I'm very sorry. But I'm just going to be talking about the pandemic. I'm going to try and talk about some vicious circles, some of the brilliant science, and where the science wasn't enough. I told you it's not going to be fun. So I'm going to start by just reminding people what the COVID infection pathway is, and then go through a couple of vicious circles, one for transmission and one for deprivation. And then talk about the brilliant science, right? How does science help? What does science tell us about the interventions that we could be doing to tackle the pandemic? What did we do? What didn't we do? And then I'll just summarize at the end. So, the timeline of a coronavirus infection. There's exposure. You don't always get infected just because you're exposed to it. But say you're infected, that's day 0. And typically, you become infectious about days 2 to 5. That's why contact tracing has to be quick. You have to get people when they're still infectious. And if you develop symptoms, you'll typically get them about a day or 2 after you become infectious. And a few people never develop infections and symptoms, and that's an asymptomatic infection, but they're still infectious. If you do get symptoms, most people recover at home. They're non-hospitalized. A few people end up in hospital. That's typically about days 5 to 14. It's often in the second week of infection that people deteriorate. Now, from all of those different types of infection, asymptomatic, stay at home, and hospital, there are 3 outcomes. You can recover. Most people recover and get better. Some people develop long COVID. The worse your symptoms are, the more serious your initial disease, the more likely you are to get long COVID, and that basically means you never really fully recover. You get symptoms that go on for a long time, often several months. Or, the worst outcome, obviously, is death. That is rare, but it does happen. And if enough people get infected, you get a lot of people dying. And what also became clear throughout the first year of the pandemic is that it's not a one-and-done thing, that after you've recovered, or if you have long COVID, you can still get reinfected, particularly if there's a new variant. Typically, it takes several months for you to become infected again, but it can be quite short if there's a new variant that turns up. So what's the impact of it? So in this stage, when you're infectious, there are basically 2 impacts. One is that you can infect other people, particularly if you're not isolating, and then the kind of wave continues. Or if you're isolating, then obviously there's a big impact on you and your employer or your work, where you're not in work and you're not in education. If you've got symptoms, particularly, you tend to be off work for longer or out of education for longer. And if you're in hospital, there's obviously a strain on hospital capacity. And there's then potential for in-hospital transmission, which has been quite a big issue throughout the pandemic, where you can infect healthcare staff and other patients. Death is the ultimate bad outcome, but long COVID also is actually really serious and increasingly being recognised as that adds burden to the health system. People need a lot of care. There are massive waiting lists now for long COVID clinics in the NHS, but also it takes people out of the workforce. And if you recover from acute infection, you're not necessarily off scot-free. Several studies have now shown that for at least a year after infection, even in people with really mild illness, there's increased risk of organ damage, heart attacks, stroke, and death. So it's joyous. Vicious circle for transmission. So I'm going to start with this. So this is I'm going to start with like a high number of infections. And typically when you have a new wave, it often starts in kind of under-vaccinated populations who tend to mix. Nowadays, that's basically children in school. It's not that children are predisposed to getting COVID, it's that they're far less vaccinated than adults, and they go to school every day with hundreds of other people. So they tend to be more exposed, so that's often where infections start. And you end up with, a high level of COVID in our population. And this is just from the ONS infection survey in England, which randomly tests about 100,000 people every week. It's nothing to do with people coming forward for testing, so it's a really good sign of how much COVID there is. And you can see, particularly since Omicron over the last year, we've had really high levels of infection. We've never really had much lower than 1.5% of people infected at any one time, and often it's been up over 5%. Now, a lot of these are now reinfections, so some professors at London School of Hygiene tried to see, well, how many actual infections have there been? And they found there have been enough new infections now to infect almost everybody in the population twice. Now, some people have never had it, some people have had it 3 or 4 times, but we're in the age of reinfection. And by age, the most number of new infections is in school-aged children. They've had about 2.5 infections per child in the UK. So, when you have a high number of infections, what happens? You get a lot of people off work sick or off education sick. In 2021, the Office of National Statistics said that COVID accounted for nearly 1 in 4 of all occurrences of sickness absence. We don't have 2022 figures yet. If a lot of people are off sick, there's more pressure for people to go to work, right? Everywhere becomes understaffed. And particularly this year, when it stopped being a legal requirement to self-isolate, it means that actually offices have a sick pay problem. They want you to come in. They don't want to have to pay extra sick pay. And so there's a lot of pressure now on people to go to work or school, even if you're COVID positive. And so what that means is that if you have more sick people at work, you get more exposure, more infection. And every time someone is infected with the virus and it replicates, there's an opportunity for it to mutate. And the more mutations there are, the more chances there are that it's going to stumble on a better version of itself. And that leads to new variants. And so just looking again at this chart of prevalence of COVID over time in England, this is it broken down by the different variants. So the original variant we had until December 2020, then we had the Alpha, the really bad Alpha wave in 2021, then Delta came last summer in 2021, and then since this year we've had 3 really big, all Omicron variant waves. The more infection we have, the quicker these new variants come in, and we've been seeing waves every 3 or 4 months. The wave we've just had is probably a waning immunity wave, but there is a new variant out there. It's BQ1, BQ1.1. We'll probably see a wave from that in a few weeks, so look forward to that. The good thing this time is that we have been boosting, so hopefully actually its impact will be blunted by that. And so then, when you get a new variant coming dominant, you get a new number of infections, and the cycle starts all over again. And if it didn't matter, if there were no consequences to infection, you might say, fine, I will live with that. But lots of infections do have consequences. So the first one is on education. So we've had really severe disruption over the last year for children learning in school. We've had lots of children and teachers being off with COVID, even after contact tracing in schools ended. So for instance, during the January peak, which was the worst one this year, there were some days when 5% of all children and 5% of all teachers were off with COVID on a single day. I mean, that is a huge amount of disruption. We've also seen long COVID now starting to make itself felt on education. The Dean Zahawi this summer said that 1/3 of secondary schools are struggling to recruit and to staff because of staff with long COVID. And there's the unions have been raising this issue that long COVID is eroding the workforce, which could have devastating consequences when we already don't have enough teachers in this country. And talking of long COVID, there's just the general impact of long COVID. So the Office of National Statistics, as part of its infection survey, asks people if they've recovered. So it's one of the only random surveys of long COVID prevalence in the world. And the most recent data that came out this month goes up to people infected before August 2022. And 2.3 million people said they still had symptoms after 4 weeks. That's more than 3% of the entire UK population. 1.8 million of them had had them for more than 3 months. And now about 600,000 people say it doesn't limit them. They still have symptoms, but it doesn't limit them, which is great. But the rest say it does limit them, and 340,000 people say it limits them a lot. And many of those people will not be able to work or live a life that they had before. So limited to some extent is 2.5% of our entire population. And that number has almost doubled since the summer of 2021, when most adults were double vaccinated. So vaccination has helped, but it has not got rid of the problem. We can't say we're all vaccinated, long COVID doesn't apply to us anymore. Over 1 million people have developed long COVID since the start of vaccination. If you have lots of people off sick, that obviously has an impact on them in terms of deaths and the NHS. So let's just kind of look at that now. Let's look at deaths first. So this is weekly COVID deaths in England with COVID on the death certificate. This is deaths from COVID, not with COVID. And in the kind of the first year, we had the two really devastating waves that were largely pre-vaccination in the UK, where thousands of people were dying every day. And in that first year, 143,000 people died from COVID. Don't let anyone ever tell you that COVID was mild. But in the post-vaccination era, we could see that between those waves, after the lockdowns that we had, deaths went to almost zero in England. But once we opened up again, Delta came and then Omicron came, there's been so much infection around that we're actually still seeing a really high burden of death. So in the last year, since summer of 2021, 47,000 people have died from COVID. Since this January, 28,000 people have died from COVID. And that isn't, we've still got 2 months to go of the year. If you compare that to an average pre-pandemic annual death from flu and pneumonia, not just flu and pneumonia from all causes, that's about 27,500 deaths. So we've added a new disease to our population that has a really high burden of death. So it's not a cold. It obviously also has an impact on people in hospital. So this is hospital admissions in England over time with COVID. You can see the enormous waves in the first two waves, but actually since Freedom Day, since July 2021, there's been a really high sustained burden of admissions in the NHS. Now, at the moment, about 40% of them are directly because of COVID, people needing treatment because they're sick with COVID, and the rest are people who are there for another reason. About a third of these are people who catch it in hospital. And that's not a good thing, right? You're in hospital for a reason, you're sick, you're more vulnerable, and then you get COVID on top of it. At the very least, it's going to delay how long you get out and lead to more NHS backlogs. At worst, it's going to make you sicker. So those are kind of the impacts on the individual, but what is the impact on the NHS as a whole? Now, not all of these impacts are directly because of COVID, but we went into the pandemic with a really lean healthcare service. It was under-resourced. It was kind of operating on a shoestring. And it didn't have the resilience that it needed to come out of the pandemic whole. So you may have seen lots of kind of articles about NHS crisis and so on. And that's because there is an NHS crisis, and it's been going on for at least a year now. So this is average ambulance response times from 2018 to 2022, ordered by category. So the lowest ones are the most urgent, where it's literally you have to be there in minutes or the person dies, up to the least urgent in grey. But since July or May 2021, they've been consistently high and higher than average. Even the most urgent ones have gone up by a few minutes, which matters when it comes to saving lives. And there's no sign that these ambulance response times are coming down anytime soon. If you're in A&E, you're having to wait a lot longer. So the target is that only 5% of people should be seen longer than 4 hours once they get to A&E. That's currently almost a third of people. It's the highest it's ever been. If we actually look at waits longer than 12 hours from arrival to admission, so you're sick enough to need admission to hospital, it was effectively zero for years. It started going up a bit just before the pandemic, but since the summer of 2021, it has been shooting up, and now 7% of people have to wait longer than 12 hours in A&E before they get admitted. And there have been, a host of newspaper stories of NHS people trying to sound the alarm. And kind of the bottom quote is from the president of the Royal College of Emergency Medicine. And he said the NHS is breaking its promise. The promise is that we pay taxes and the NHS will be there when we need it. And it hasn't been there. And if you're well, you don't realise it. But the people working in it and the people who need it do realise it. And it's actually quite scary. Don't get ill. Away from emergency care, kind of normal treatment. So the number of people waiting for treatment in England, this is now from 2016 to 2022. Again, it was going up ever since 2016, but slowly. it actually dipped the summer after the first wave because we had enough spare capacity to eat into that backlog. But since then, it's been going up steadily. Normally, you use summers to kind of eat into your waiting list when demand is lower. We have not had a low demand summer this year, and we didn't have it last year. And we had high waves of COVID both in 2021 and 2022 summers. And we're now at 7 million people waiting for treatment. It's a record. It's 1 in 8 of the entire population are waiting for NHS treatment. And it matters because there's been studies by the Financial Times saying actually they think that this is contributing to the labour shortage because people can't work, they're too sick to work. And also has consequences for people in that they're dying on the waiting list, waiting for treatment. And then there's the impact on staff. So this is the percentage of staff absent from the NHS because they're sick. It's not just COVID, it's all sickness. The dotted and dashed lines are 2019 and 2020. The red line is this last year, and this goes up to March 2022. And you can see that staff sickness has been the highest it's been, and you can see specific spikes. The first one is the Delta spike, and the second one is the Omicron spike in January, when almost 10% of NHS staff were off sick. And then the last one was just coming up into the March wave that we had. And that also has a massive impact on the NHS's ability to look after people. And it's causing a lot of stress. And we're having this big recruitment problem in the NHS now. People are leaving. Paramedics are leaving. GPs are close to breaking point. It's really hard to get a GP appointment now. And nurses are leaving in record numbers. 1 in 9 nurses left last year. Highly trained people that we need. So that's the impact on the NHS. And it has a general impact on our economic life, right? When you have a wave, a lot of people are sick all at the same time, and that causes problem, right? It causes massive absences. Flights are cancelled, theatres cancelled, your plans are cancelled, public services are operating at a much lower level because so many people are off sick. I think we've all experienced now when things have happened because there've been too many people off sick with COVID. And on a longer term, you have the long COVID workforce disruption. So long COVID is highest in adults aged 35 to 69. 5% of everybody in that age group says they've got symptoms lasting at least 4 weeks. That's a lot of people off work for a long time or not as able to be as productive for a long time. And again, that's going to affect their productivity. The FT, ran a story saying long COVID now a major cause of long-term work absence. The Bank of England raised this as an issue in May, saying that long COVID has been one of the main drivers of the shrinking labour pool in the UK. So that's kind of your circle of transmission. So now I want to look at the circle for deprivation, because this is, to me, one of the most depressing things about the pandemic, and we've known about it since May 2020. And we've done literally nothing to stop this happening. So the first thing is, for people in more deprived areas, they're less likely to get tested to begin with. And we saw this, Liverpool did a mass testing pilot in autumn of 2021, and only 4% of people in the poorest communities came forward for a test. And now, of course, they're less able to afford to because we have to pay. And are you really going to spend £5 on 2 tests when you're struggling with this cost of living crisis? If you do then test positive, you're less able to isolate, right? You're living in overcrowded housing, so you can't keep yourself that separate from your roommates. There's poor housing. Many people, especially in the gig economy or freelancers, cannot afford not to go to work. England has one of the lowest sick pay rates in Europe. Statutory sick pay is very, very low. And also, you're not in a position to work from home. So like when I had COVID, I could work from home, and I didn't really have to take any sick leave. If you can't do that, you're forced either to take sick leave and sick pay or no sick pay at all. People are more exposed. So again, going back to the housing issue, you're more likely, because you're living in multiple occupancy housing, to be exposed to people who have COVID. You're more likely to live in multi-generational housing. So older people are more likely to be exposed. There's less access to green spaces, right? We know outdoors is pretty safe, but then if you want to hang out with people, you want to go somewhere nice to do it. If you don't have access to that, you're more likely to go inside again, which is more risky. And also, people are more likely to be working in public-facing roles where they're exposed to a lot of different people every day, and that increases their risk of catching COVID. there was a study that came out in 2022 that actually just kind of said this. They looked at it rigorously, scientifically, and they said, people living in the most deprived regions of England and Wales had elevated risk of exposure to vehicle sharing, public transport, work and education settings, essential shops, non-household contacts. And this is all during the autumn-winter wave of COVID in 2020, 2021. And they said that consistently elevated exposure will contribute to the fact that they're more likely to be infected. And once they are infected, people are less protected because vaccination is very different according to deprivation. This is the most recent data, it goes up to July 2022. It's age standardized because people in more deprived areas like to be younger. And what it shows is that people in the most deprived quintile are almost twice as likely not to be vaccinated at all as people in the least deprived areas. And even once they have 1 or 2 doses, they're more likely to then drop out and not get booster dose. Only 62% of adults in the most deprived areas have 3 vaccine doses compared to 83% in the least deprived areas. So this again means you're just less protected if you do get sick. And then if you do get sick, you're less aware of symptoms. There have been several studies now showing that people in more deprived areas are much less likely to be able to name the main symptoms of COVID. And we've had incredibly poor symptom communication in the UK for the last 2.5 years. For 2.5 years, we were told it's a high temperature, a cough, or sense of smell and taste has changed. And that's the only thing that would get you a PCR test. That's the only thing that they made that said to people, use an LFD. We've known since 2021 from the symptom tracker app and loads of other different things, including the ONS infection survey, that the symptoms are different, especially after vaccination. There was runny nose, headache, sneezing, sore throat. It was muscle aches, nausea, diarrhea. And what makes me so angry about this is that in March 2022, just after they stopped free testing, they updated the symptoms. So make of that what you will. So this is kind of the deprivation cycle. And it has consequences. And the consequences are that up to December 2021, people in the most deprived areas had more than twice the death rates of people in the least deprived areas. Much more likely to have long COVID than people in the least deprived areas, which again makes you less able to work, which only exacerbates any poverty issues. And these cycles, they interact with each other, right? When you have a new wave of infection, it disproportionately affects people in more deprived areas. And again, if you have high levels of virus circulating in more deprived areas, it's going to feed back into the general high infection cycle. So these things aren't independent. So how about some good news? So what has the science told us about things that we can do about it? Well, the first one, obviously vaccines have been amazing. There have been the 3 main ones we've used here, AstraZeneca, Pfizer, and Moderna. Most of us will have had 2 of those, probably, in terms of types. But there are actually 172 different COVID vaccines currently in clinical development, and another 199 that are preclinical development. Vaccines and their research has not stopped. We're trying to find vaccines that are more variant-proof, that are longer-lasting, that are easier to store, because Pfizer, for instance, has to be stored at -80, which makes it very difficult to distribute in some parts of the world, that are easier, or nasal vaccines, or vaccines you can swallow. So much easier ways of delivering it. So this has been incredible, right? To date, almost 13 billion vaccines have been given across 184 countries. We now know masses about how safe they are and how effective they are. And to go from a new disease in January 2020 to vaccines by December 2020 is really an extraordinary achievement. We've also been extremely good at new treatments being identified and developed, and the UK has played a really leading role in this with this trial called the recovery trial. And what it did is it massively streamlined how you recruit patients into a trial, and it was kind of ongoing, so you could test new treatments all the time. And they were the ones that found that kind of a really easily available steroid was really useful, so that was really important. They also did some really important things by showing things that didn't work. They showed that hydroxychloroquine does not cure COVID, for instance. Pfizer and some other companies have also been developing specific treatments, both antivirals and the monoclonal antibody treatments that have been saving lives, like Paxlovid is now available in the NHS to vulnerable people if they get COVID. So that has been another really big success. Mathematical modeling has had its detractors over the pandemic, but actually I think it has made a really positive contribution. There's no other way of really thinking about the what-if scenarios. What happens if I do this? What happens if I want to do that? And once you've done it, how do you know if it works, right? To do that, you kind of need to know what the counterfactual was, and that's where mathematical modeling has been incredibly useful. It was also really important in determining our vaccination strategy when we vaccinated the older populations first, which was really effective back in 2021. Understanding who are at risk, right? This is science. When COVID first came, we didn't know who it was going to affect. And say with flu pandemics, we've seen some flu pandemics affect older people, some flu pandemics affect young people. So again, it was really important to work this out. We had the various ONS surveys. We had what was called the Imperial React study, where Imperial College tested about 150,000 people every month for 18 months in great detail and explored what happened to them. We had existing national audits from our centralized healthcare system that looked at everybody in intensive care, everybody in hospital. So we could work out really quickly who was at risk and try and understand that better. And surveillance, actually. The UK is one of the countries that has the best surveillance for COVID in the world, and it makes all the data publicly available, which is really beneficial and something we should be proud of. The Office of National Statistics has been amazing with its infection survey, its long COVID survey. It also is monitoring economic impacts, social behaviors, deaths, deprivation, and so on. The UK Health Security Agency has been publishing weekly reports on vaccination, on surveillance, on outbreaks. It does COVID variant risk assessments, which are the best in the world, really. It's one of the best ways of rapidly finding out what is the impact of this new variant, how effective are vaccines, how severe is it. And talking of variants, we have the COVID Genomics Consortium in the UK. Again, that's a world leader in sequencing PCR tests and spotting new variants and trying to understand about them. Now, unfortunately, in the UK now, we're only doing a few hundred PCR tests a day, and that's massively impacted how much we can learn about new variants. Now we're learning about them very late because we're just not sequencing that much. And the other thing that science has done, which we don't hear about as much, is transmission and preventing it. So this is actually a paper from September 2020, and it was discussing the fact that, the COVID is airborne. And it said there are all these different ways that you can try and prevent infected aerosols, so virus and little air droplets called aerosols that how can you prevent people inhaling that and becoming infected? There have been loads of studies showing that natural ventilation, which is basically opening windows and doors, is really good at preventing transmission. It basically refreshes the air. It takes the aerosols out of the room. There's also been various studies showing portable air cleaners, so HEPA filters. What they do is they directly take the aerosols that contain the virus out of the air and filter them out so the air is purer. It's been shown that they work really well, and also that they're very cost effective. You can also have UV light, and what that does, it doesn't remove the aerosols, but it kills the virus inside the aerosols. It also kills bacteria, by the way. And one of the problems with UV is that it can impact human skin, which is why it's not been used as much, but there's this new wavelength, the far UVC, which doesn't harm human skin. And a new paper that came out of the UK in March 2022 says that actually within 10 minutes, they had reduced the pathogen load in aerosols by 98%. Now that, if we can roll that out and scale up, that's a game changer. It basically makes it like the outside. We also understood a lot about masks, right? The science has understood a lot about masks. Whether that's made it into policy is a different thing. This is a paper that came out in June 2021 on different masks, on surgical masks and FFP2. So an FFP2 mask just has a filter in it. It looks like this. It's quite cheap. You can reuse it. It's quite comfortable. And what they showed is that if compared to two people, both wearing a surgical mask, but you have about 10% infection risk, you can take that to 0.1% if they both have a well-fitting FFP2 mask. It's a massive difference. Have you heard about FFP2 masks in the UK? People don't talk about it. In other countries, they talk about it. And ideally, you combine those two things together and you can prevent a lot of exposure. So, there have been lots of studies now showing that with masks and open windows and filtration, you can cut infection risk by over 90%, unlike in public transport or in schools. We've also understood what it isn't, right? When we came in 2020, people thought it was surface-driven. And that's why you have all of this emphasis on sanitation and hand sanitizers and hand washing. But it's very clear now that's not what happens. The USA Centers for Disease Control said the principal mode is through respiratory droplets, which includes aerosols. Contact with contaminated surfaces is a risk considered to be low. And the European Centre also says transmission of SARS-CoV-2 from surfaces plays a very small role. The primary role is aerosols. In January 2021, there was an article in Nature saying COVID does not spread through surfaces. Why are we still deep cleaning? And what do we see? You go everywhere. There's hand sanitizer. Don't care, right? It's good to have clean hands. It's not going to stop you getting COVID. It drives me crazy when you go into a shop and they offer you hand sanitizer, but no one's wearing a mask. It just makes no sense. So, this is all science. The science of transmission is science, but it's physics and it's not medicine. And we've heard much less about it. And I really don't know why we also just haven't acted on it. So, how does that science kind of lead into potential interventions? So, let's think about the things you can do. You can reduce exposure, to begin with. So the really specific way of doing it is to ask infected people to stay home and potentially infected people who tend to be their contacts. That's how contact tracing works. If you do it really well, you can get away with really not doing much else, which is kind of what South Korea did and Japan did. Although Japan also did a lot of ventilation. If you don't know who's infected, then it's things like lockdowns, limits on gatherings, working from home, social distancing, behavior change. It's all about trying to keep you away from other people and reduce the risk of infection. It's not a very targeted intervention, unlike contact tracing. Or you can reduce the impact of exposure. That's saying if you're in the same space as people who are infected, how can you reduce the chance of you actually getting infected? And that is things like it's masks, it's outdoor interaction, it's clean indoor air, like the things that we've just been looking at. And then you can reduce the impact of infection. You can say, okay, but once someone is infected, how do I prevent that from having a bad outcome? And that's things like new treatments, it's access to treatment, it's also healthcare capacity. If you don't have healthcare capacity, then the impact of infection can be very severe. And then you have vaccines. And the promise of vaccines is that they work across all of that, right? They make it less likely for you to be infected. They can reduce the chance of you transmitting to other people. And they also massively reduce the impact of infection. They make it much, much less likely that you'll get severely ill or die. So how do those kind of affect this timeline of COVID? Well, reducing exposure or reducing the chance of getting it if you're exposed is an extremely efficient thing to do because you're at the upstream end. And you're reducing then automatically all of the burden that comes after it. The treatment thing comes actually quite late in the life cycle of COVID. You're not going to really change the numbers of people getting COVID or the disruption because of it, but you are going to change the number of people who die or get really sick from it. And the idea was that vaccines cover all of it. And if the vaccines were perfect, you wouldn't need to do anything else. A bit like the measles vaccine, right? If you could do that, that would be great. However, with new variants and the current batch of vaccines and the tricksy way that COVID is working, it means that the vaccine immunity does wane over about 6 months, as does immunity from infection. And that means that actually the biggest impact of vaccines or previous immunity is in blunting the downstream impact, it's in blunting the severity of illness, which is really important, but it's not going to prevent the really big waves. And so what actually have we done in the UK? In the first wave, we basically reduced exposure through lockdowns. We had no idea he was infected, we weren't testing, we had no contact tracing set up. There was no immunity, so you couldn't get away with anything less than a lockdown, really, especially because we acted so late and had no testing system in place. And we had to reduce the impact of infection. There were no treatments in the first wave. No treatments for COVID at all. It was just supporting people, and they got better or they didn't. So what we did was we organised the NHS to effectively become an intensive care service for people with COVID. From late 2020 right up until the beginning of this year, we tried lots of different things. We put in vaccination, massive intervention. We had, at various times, lockdowns, limits on gatherings, working from home, social distancing, contact tracing, self-isolation. We also did then say, wear masks. We never had a message thing here about high-quality masks, which actually make a massive difference. We said open windows and outdoor interaction, but we didn't actually do that much else. And we also then put in treatments and, again, reorganized the NHS. As of the beginning of this year, the only thing we're doing is vaccines and treatments. And we've given up on everything else. But that means that the only thing we're doing is downstream, and very little will be affecting directly infections. And you can see that in the ongoing high number of waves that we're having this year. Now, immunity from both vaccination and previous infection is making this better than it could be, but we're definitely not in a situation where it's fine. And really what we're not doing are any of the kind of upstream things of reducing impact of exposure or reducing exposure. And the added benefit of those is that they're variant agnostic, whereas the vaccines really do care about what the variants are, and the successive variants are all more immune evasive. These things don't. Having clean air works against any variant. Wearing a mask works against any variant. It works against any disease that's respiratory, right? So it will work against the next pandemic. If you're interested in pandemic preparedness, those are the things you want to be doing. And it also will work against flu and cold and other airborne diseases. So let's just have a look at kind of some of the issues that we had in implementing the interventions that we tried. So the first thing is we did do contact tracing. We did. But there was no routine testing of contacts, which other countries were doing, which really doesn't make any sense, because the whole point of contact tracing is that you've identified a group of people who are more likely to be infected, but you don't test them. We had the poor communication of symptoms, which meant a lot of people didn't come forward for testing to begin with, in which case they never enter the system and you don't contact trace them. And we never really offered financial or practical support to people isolating, which meant that a lot of people just could not afford to do it, or they had other responsibilities. And if the people who you've contacted aren't isolating, the whole system is a failure, right? It's not a success because you've contacted somebody, it's a success when they isolate. We've done nothing to improve the deprivation cycle, nothing. We've done nothing to improve poor housing or workplace conditions or anything else related to health inequalities over the last 2 years. We haven't improved vaccination rates. The vaccination gap has been there since 2021 when we started. It's still there now. And we haven't addressed exposure through environmental improvements at all. Other countries are doing it. Japan, Belgium's recently put in legislation that says all workplaces, public spaces have to put in ventilation controls, have to tell people what the ventilation is like. Like I noticed for this conference, yes, there's emphasis on testing and masks, which is great. Not a word about ventilation. What is the ventilation in this room? What's the air exchange rate? No idea. And these are policy issues, right? We've had brilliant science, but it can't tackle this. This isn't science, this is policy. And so that's where brilliant science is it's necessary, but it's not sufficient. And so just kind of the last slides, a kind of summary, is I hope I've shown you that there are many vicious circles in coronavirus transmission and impacts. I've only shown you 2 of them. And the problem that we're trying to solve right now as a country or globe seems to be, how do we return to 2019? Well, we can't, right? We've got a new disease. Sorry, we can't go back. And the worst thing is that we seem to be stuck in 2020 responses to it, relying entirely on the downstream medicalized kind of solutions and hand sanitization and hand washing. And we're not really reacting to the knowledge that we have gained through science. And the problem we have to solve is, how do you interrupt those vicious circles? And so really, that's where I've been trying to persuade you that addressing the key drivers of exposure is much more efficient, much more sustainable. It doesn't actually restrict anyone's freedoms, and it has benefits that go far beyond coronavirus. And the next wave is on its way, probably in the next few weeks. There'll be more next year. But so is the next pandemic. And that really should be worrying us. And so the sooner we start addressing these things, the better. And that's it.